Thank you very much, and I apologize for my tardiness. I have endless enthusiasm, but my time management skills deteriorate annually. I have been back in Canada 18 years, and when I first came back, the studies that were being done in myeloma had to do with pomalidomide and Zometa. And none of the new drugs that we will be talking about today had reached the clinics. So it's really been an amazing almost 2 decades to see how management of the disease has been transformed. I didn't bring a disclosure slide, but I have many disclosures. Although I do not own any personal stock, I'm not employed by any drug companies. However, my program has research support from all the major pharma that make myeloma drugs, Celgene, Janssen, Takeda, Amgen, Otsuka. And I have been on advisory boards for most of those companies, and have also been an expert witness before Health Canada to try to put into context where a new drug might fit in, with the not-so-secret goal of trying to get as many drugs approved as fast as possible, and also on Ontario boards that will be looking at funding and the role. So I think it's important to set the stage when we're talking about a particular setting of myeloma. And today this session is going to focus on management of relapse disease. And I think we need to keep certain aspects in mind because, as all of you know, this is an incredibly heterogeneous disease. It's at least 7 subtypes. And all of our managements, our clinical trials, treat it as if it's one disease. And then we try to sort out, well, did a certain characteristic mean that patients were going to do better or worse? But we really haven't solved this problem. We do use fish cytogenetics as a first level characteristic, but there are now even deeper and better ways to define risk. And of course, cancer doesn't follow rules. I think another major shift as we talk about relapse disease is there's been a big shift in management of first-line treatment. And so whatever patients get at the beginning affects the choices, both in terms of effectiveness and in terms of what's funded downstream. And now lenalidomide maintenance after stem cell transplant is considered standard treatment. And for older individuals, about 80% are now considered good candidates for lenalidomide and dexamethasone, as opposed to the older regimens that were what we called fixed duration, usually 9 cycles of a bortezomib or Velcade-based regimen, and then treatment was stopped. And of course, now we really are in the era of immunotherapy, and we finally have funding of daratumumab triplets, that is 3-drug treatments. So if we look sort of at a snapshot of how myeloma is treated across Canada at diagnosis, and I think you've probably heard this from other speakers, in Canada and Europe, I think we all agree it's still important to consider transplant in virtually all eligible patients. The age limit fluctuates a bit. And if patients are less than, in our center, it's about 71, they receive Cybor-D and then lenalidomide maintenance we've had available since 2012. And older individuals will have VMP, which was Velcade or bortezomib melphalan and prednisone, which we've tweaked to use cyclophosphamide instead. And as of a couple of years ago, an alternative is continuous lenalidomide and dexamethasone. That's continued until the disease progresses. And then after relapse, there's 2nd or 3rd line treatment. And traditionally, we have offered a second transplant because we store stem cells on almost everyone in this situation to offer them a second transplant at relapse. Now, we have been using our database both nationally and locally to say what kind of results are we getting in this setting. I mean, we need to be hitting certain benchmarks. And we're happy to say that with Cybor-D After transplant, the overall response rate is very high, and almost 80% have at least a 90% reduction in their protein. And even though this is not a research population, our median progression-free survival with lenalidomide maintenance is exactly what was seen in the clinical trials. It's pushing 4 years. And there's going to be an update of this using our national database in hundreds of patients that we hope will be presented at the IMW meeting. And I think it was extremely promising. So I think there's a lot of enthusiasm for continuing this. And then for CyBOR-D, VMP, and RD, we've also used the national database, and our response rates and progression-free survival are exactly what the clinical trials showed, even though we were talking about patients that were not necessarily in that very healthy group of clinical trial patients. These were patients that were on dialysis, they had low blood counts, they would have never made it on a clinical trial. So I think our benchmarks are pretty good. So despite the progress we've made in first-line treatment, we do have to face the reality that relapse is almost inevitable. And I think there are 3 general groups of patients that we as physicians take into account when we're trying to design the next or recommend the next line of treatment. The first are those that never had lenalidomide, may have been treated before it was available, or may have declined, or it wasn't the best treatment for them. Then there are this emerging group of patients who've progressed on lenalidomide or Revlimid as part of first-line treatment, as I've just described. These are the maintenance, or those who are older that have Len-Dex as their first-line treatment. And then there's this subset in whom we're still offering a second salvage transplant. Now, in the past, this afforded about 1.5 years median progression-free survival. And of course, medians have people longer, have people shorter. But we don't have just yet, is that still what we'll see in our patients that will be and are progressing on lenalidomide maintenance? And that is the subject of a Princess Margaret and also a national database analysis. Now, if patients are going under a second transplant, we usually reinduce remission with 4 cycles of treatment, and I think there is a desire to avoid using up one of these highly effective new triplets for just 4 cycles, because such treatment may be very life-extending later on. So this is a question of optimal, how to optimize this. And there are other choices besides these exciting new triplet regimens. So when we're trying to consider what treatment should be offered or recommended in the relapse setting, obviously there are a number of factors that go into this. There are those that have to do with other toxicities a patient may have sustained, what the kidney tests are, how are the blood counts, what we call bone marrow reserve. Some drugs are hard to give if you're starting out with a low platelet count. And then one shouldn't minimize the effect of the route of administration. It can be very hard to get to clinic or to get to the chemo infusion center multiple times a month if one lives far from the center or doesn't have reliable transportation. We do try to consider the biology of myeloma. Some relapses are incredibly indolent and don't warrant treatment. And in some individuals, observation, I think, can be considered a line of treatment. If the subclone that's emerged is not causing any harm, do we need to jump in and treat it, which is a whole area that we don't understand completely. And then, of course, we have to consider the toxicity of the treatments that we're offering. Despite all this, really in Canada, we are driven by what is funded. And although there are constraints, I think it's important to keep in mind that we are a lot better off than many countries. Pomalidomide was just approved in Australia for use. And I think and maintenance was only thalidomide. So I think even in first world countries, there's variability in what is publicly funded. And I don't want our funders to hear this, but I think it waxes and wanes too, but we are able to access really most of the drugs that are really the key ones to extend patient survival in Canada, of course after a lag for all the regulatory and funding considerations. Another factor that's become apparent just in the last few months is with these good new triplets that I'll be discussing in more detail later, most provinces are limiting funding to 1 triplet per patient. That may sound stingy, but the triplets were not studied where you use one and then another and another. So in the absence of data, it's hard to push for this approach. But I think I'll try to illustrate why that is the case a bit in a minute. Now, I'm going to show a lot of tables and try to make some summary comments about these tables and then try to pull it together at the end. So if it seems confusing, please just close your eyes and take a snooze and wait for the final slides. But as I get older, I feel like a medical historian. But I think it is useful to go back to the regimens that we have used for relapsed myeloma, because some of these are still quite reasonable options, even in this current era of exciting new drugs. And if we go back to the kind of mid-2000s, the introduction of lenalidomide and dexamethasone for relapsed myeloma was a huge step, a huge advantage for patients. And I've just shown some results to give you an idea of expectations. Now, one of the really important considerations in looking at patient disease outcomes in relapse is whether a treatment's given for first relapse, second relapse, third relapse, because the disease tends to get smarter with time. It gets harder to treat with time. So in general, the remissions are shorter with each different line of treatment. So if you look at a group of patients that's getting a treatment and it's their 4th treatment, that treatment is likely not to work as well as if it was the 2nd treatment. And that just has to do with the disease biology. But keep in mind there are plenty of exceptions. I always go back to an individual who had a transplant many years ago and on day 100 had a marrow full of myeloma. That's supposed to be terrible. That's 3 months later. Had a 7-year remission with Lenalidomide Dex. So, you know, we really can't predict the course in any one patient. But if we go back, these studies, all patients had all had a median of 2 prior regimens, so that's getting down the road a bit in relapse. But if you look at some Canadian experience with lenalidomide and Dex, we got a little over a half year, but the recent trials with 1 to 3 prior regimens, the Len Dex alone gives close to a year and a half and can be quite useful as the second treatment for first relapse. Our good old Cybor-D or Cybor-P, if you use prednisone, has about a 70% response rate in about a year, which is not bad. RVD, which is not funded in relapse, this is a published phase 2 trial. This we think is a little low, but a bit under a year, and then you can add cyclophosphamide to lenalidomide and Dex, and you can also get a year, year and a half. So these regimens can be brought back under certain circumstances and can certainly be helpful. Now, in going through the next set of tables, I just wanted to go back and talk about the drugs that are included in these triplets, and just to review that the main classes of anti-myeloma drugs include steroids, dexamethasone and prednisone, so-called alkylating agents. These are more old-fashioned chemo drugs, high-dose melphalan's what we use to get the punch from a stem cell transplant. And then we use weekly or now every other day low-dose cyclophosphamide as well. Proteasome inhibitors were really the first next big step in treating myeloma. These drugs inhibit a particular enzyme that's very important for keeping myeloma cells alive. And if you block that enzyme, the cells die. And again, bortezomib, known as Velcade, was the first one. We now have an oral one called Ixazomib, the brand name's Ninlero, and a probably more potent one, carfilzomib or Kyprolis, which is intravenous. The immunomodulatory derivatives started with thalidomide, and then we really don't use that anymore, but we have lenalidomide, and then pomalidomide. And then, of course, the monoclonal antibodies, what is approved by Health Canada and now funded in certain situations is daratumumab or Darzalex. The trials report response rates and then progression-free survival. That's the amount of time, usually from starting the treatment until the disease meets certain criteria that we can call it progression. And that means half people have longer benefit, half people have shorter benefit. And the PFS does not, of course, tell any individual their own destiny, but we have to have some way to reference what these treatments do to tell our patients the general expectations. Now, the whole recent generation of trials has compared Len-Dex, that doublet, so to speak, and I just showed you the results in relapse disease, with Len-Dex and a third new drug, and that's the triplet. And there's a second set of studies that compares Velcade and Dex or Bortezomib and Dex with that combination plus a new drug, with one exception. So again, I'll launch off into these trials that have led to the approval and funding for relapse disease in our country. So the first set of trials, and I've also indicated their nickname because sometimes this rolls off the tongue easier than saying Len-Dex carfilzomib. But the first trial that really had everyone sit up and take interest, and of course was led by Keith Stewart, who unfortunately defected to the US, but did a lot of good in Canada. Pardon? Yes, but still has close ties and left a wonderful legacy here. And he was the lead investigator. So the Aspire trial compared Len-Dex with Len-Dex and intravenous carfilzomib at doses that are at the low end of what we can use. And then the Tourmaline trial compared Len-Dex with Len-Dex and the oral proteasome inhibitor. It's not quite oral Velcade, but close enough for government work. And then there are trials in which Len-Dex was compared with Len-Dex and a monoclonal antibody that is called elotuzumab. This regimen was approved by Health Canada, but is not being marketed in Canada. And then, of course, the Pollux trial, Len-Dex versus Len-Dex daratumumab. So again, first of several tables, but I wanted to make some points. I've shown what the third agent is over here. And then we are not supposed to do cross-trial comparisons because patients that go on to these trials may differ according to the eligibility criteria, but we don't have another way to try to help decide what treatment might be better than another. But I would point out some features that we have to take in mind because these studies were started years ago, and the treatment of myeloma is a very fast-moving train. And when you look at these trials, very few patients had lenalidomide, had Revlimid, and they certainly couldn't be refractory to it because the control arm was Revlimid and Dex. That would be unethical to randomize patients to a treatment that is highly likely to fail. And on the other hand, the majority had Bortezomib, close to 70%, but except in the monoclonal antibody trials, patients could not have progressed on bortezomib. And if someone is progressing on treatment, we generally think that is a more resistant myeloma than if someone progresses off treatment. That's basically what refractory means. We look at cytogenetics, but they tend not to be as informative once people have moved beyond first-line treatment. But despite these caveats, if you look at the triplet, the response rates are from 80 to over 90%, and the progression-free survival is always better with these triplets and is 1.5 to 2 years, and with DRD, with daratumumab, it's a whopping 3.5+ years. And you can see the control arm does reasonably well, and as what I showed you previously is for RD alone is 14 to 18 months. Now, I think what we would all want is to be able to tell ahead of time who's going to be the patient with Len Dex who's going to have 7 years, like my patient I described, because maybe that individual doesn't want the hassle or toxicity of a third drug and maybe doesn't need it. You can save that third drug later on. But we don't have that ability at the present time. The progression-free survival curve for DARA-RD is really quite impressive, as you can see here, and has led to a tremendous amount of excitement among everyone involved in the area of myeloma and has recently been funded. Now, when we line these 3 regimens we have available in Canada, I've just shown again here the information, the superiority of the 3 drugs versus 2 compared to lenalidomide Dex, and then without any sarcasm, we all know there's no free rides in cancer medicine, that there are always side effects. The only way to avoid them is not take any drugs, and that's not an option when cancer is causing problems. But when we're using these drugs and our patients are deciding about whether to go on a regimen, there are always some special considerations that we need to be aware of. So with carfilzomib, it is an agent that can make the blood pressure go up. It's usually manageable. And there is a risk of heart side effects. It's not high. It's generally no more than 5%, but there can be decrease in the heart pump function. There have been irregular heartbeats. There have been other issues. But it gives us pause if we're dealing with someone who has pre-existing cardiac issues. With ixazomib or Ninlero, fortunately, with weekly dosing, neuropathy is uncommon, but both bortezomib and Ninlero or ixazomib can cause or aggravate neuropathy. Diarrhea can be quite annoying, and we've taken to given, it's not funny, I suspect. But one thing that we have found anecdotally to be helpful, and I've started giving everyone starting ixazomib 8 milligrams of ondansetron before each dose. Not because it's particularly nauseating, but most of you know ondansetron is quite constipating. And that seems to have avoided some of the really profuse diarrhea that can occur with ixazomib. And it's what we used to see when Velcade was given intravenously and before we started using ondansetron before each dose with that agent many, many years ago, because people would have to start running to the bathroom on their way home from the chemo area, and that's not as common anymore. For daratumumab, there is some lowering of the neutrophil count, usually quite manageable, but I think the special consideration is that there are more chest infections. And we need to be very vigilant, particularly in flu season, in treating these infections, diagnosing them, because they clearly are more frequent with daratumumab. I think an important parameter to look at in all these trials is what % of patients needed to stop the treatment due to adverse events, that's AEs, that is significant side effects. And with carfilzomib, it was almost 1/3 of patients. For ixazomib, it was a little over 15% of patients, and with daratumumab, it's about 15% of patients. So if you can't tolerate the treatment, it's no good. So I think this is a very important factor to look at when we're integrating these treatments into practice. So the next set of studies are those in which bortezomib and dexamethasone is the control arm. And I will point out that the first trial, Endeavor, is not a doublet versus a triplet. It's a doublet versus a doublet. It's an exception here, but it's a head-to-head comparison of bortezomib and Dex versus a higher dose of carfilzomib and Dex. I'm not going to talk about the next two, the histone deacetylase inhibitors and the elotuzumab trial. They're not available in Canada, and they're actually not too widely used. But the daratumumab trial that added this monoclonal antibody to bortezomib and Dex is called the CASTOR trial and does have relevance to our discussion today because it is now funded. Thank you. So if we can sort of put this information together in a table, what we see now is more patients in these trials have had lenalidomide, and now we're trying to hone in on what's the best treatment for our patients that are now progressing on lenalidomide, either as maintenance or as part of their other treatment. But most of these patients were exposed, but only a minority were actually progressing. But again, with that consideration, the response rates are 75 to 80%, and we know that bortezomib and Dex as a doublet is not quite as potent as lenalidomide and Dex, probably because lenalidomide also has an immune effect as opposed to a myeloma cell-killing effect. And we also know that bortezomib and Dex is not usually how we give relapse treatment, at least in Canada. We almost always add cyclophosphamide to it. I already showed you Cybor-D tends to give you more like a year. But nonetheless, you get at least a doubling of the benefit around a year and a half when these treatments are used, and these are significant advantages. Now, this is the update of CASTOR, and one of the promising elements of this is when this daratumumab, bortezomib, and Dex is used second line, that is after one prior treatment, the benefit is better, not surprisingly. That's a recurrent theme. It's 27 months, and that gets into that 2-year benefit that in my own mind is what we want all second treatments to give us. It seems to be a goal that we want to pick a treatment that has as close to a median PFS of 2 years as the second treatment. So this slide summarizes these regimens. Toxicities with Endeavor also include high blood pressure, cardiac events. CASTOR was designed with bortezomib twice weekly. Fortunately, we're going to be able to give bortezomib weekly. CCO will let us do that, which should mitigate the peripheral neuropathy considerably. And there, again, with daratumumab, are more frequent respiratory infections, but it doesn't seem to be quite as prominent as with Dara-RD. And if you look at the discontinuation rate due to toxicity, it's really quite low. So these studies were done in patients with all sorts of prior treatments, with as second line, third line, fourth line treatment, and we've lumped all the results. But when you have a patient in front of you, they have multiple characteristics, and we can give them the median progression-free survival, but it would be ideal if we could individualize it to their particular myeloma circumstance. And these trials all have subset analysis. They look at how well does the drug work if you use it second, that is after one line of prior treatment. How well does it work if someone has certain FISH chromosome cytogenetics? How well does it work if someone is progressing on Revlimid or progressing on Velcade? Unfortunately, when you cut the size of these trials down to those subgroups, you get quite small numbers, and really that information's not available. And then, of course, when you're comparing across trials, we really are not supposed to do that statistically. But I'll make a couple of general points. The first is easy. When you use these treatments second line, after one prior treatment, they all do better, and this is the intention to treat the whole group. So whatever you use first is going to work better than if you used it later on, but that doesn't always tell you which of these is the best. If you take a broad view, I just emphasized the first point, but if you look at for high-risk cytogenetics, and again, everyone is different, in general, KRD, that's carfilzomib or Kyprolis, Lenalidomide Dex, and Bortezomib Dex tend to have the strongest results. And we think it's good to combine a proteasome inhibitor and an IMiD for high-risk disease. And again, for prior therapy, if someone has had lenalidomide or bortezomib before and their disease has come back, the benefit tends to be less. The disease is more resistant, relatively speaking. And if someone is actually resistant or their disease is progressing on these drugs, that generally, definitely decreases the benefit. So, 10 minutes. Okay, I think we're okay. So, the next line of treatment is usually based on the IMiD pomalidomide, which was studied, positioned, and marketed only for patients who had progressed on lenalidomide. It is the most potent IMiD, and it's been reserved for when lenalidomide didn't work. Now, pomalidomide or Pomalyst and dexamethasone by itself is better than the control, but it is probably best thought of as a backbone regimen. And in Canada, we strongly prefer adding cyclophosphamide to it, which doubles at least the benefit. But pomalidomide has been studied or combined with multiple other agents. And I think one of the exciting combinations is Pom-Dex plus a monoclonal antibody. Now, Pom-Dex plus daratumumab has not been studied in a phase 3 randomized trial, which is generally necessary for Health Canada approval and funding. But a different antibody that targets the same antigen on the myeloma cells, isatuximab, has been compared, Pom-Dex versus Pom-Dex-Isa. We don't know the numerical results, but there's been a press release that the triplet won, and maybe that combination will eventually be funded. I think we have to wait and see, and there have been some rumblings or questionnaires. Would there be an expanded access program for that? So I have no inside information, but I think my message is for those of you who feel like you may be missing an opportunity for daratumumab. I think there is a lot of hope that there will be access to monoclonal antibodies beyond the indication that we have for general funding now. Pomalidomide treatment can be moved up to second-line treatment, so there is some flexibility in sequencing. Now, this is just a very busy table showing all the pomalidomide-based triplets in the trials. They differ with how many lines of treatment, the progression-free survival. I just wanted to point out a couple. If you look at Pom-Prednisone and Dex, the median PFS when 3 prior treatments were given was pushing a year. We're very excited. Some centers in Canada have used, and this is a phase 2 trial, unfortunately, Pom-Dex Dara, and the responses have been very high, and it looks extremely promising. Pom-Dex Bortezomib also gives at least a year. in a randomized trial, and I think we'll be working through the Health Canada and funding process as well. Now, I think the other side of the coin, I've highlighted some of the special toxicities with these regimens. I think the administration schedule is another really important consideration. Carfilzomib is the most frequent visit, 6 times a month for administration until we have weekly approved. Ixazomib is oral, and daratumumab is very busy at the beginning, but after 6 months becomes more manageable with a monthly administration schedule. So if we look at sequencing, I'm going to have the 5-minute slide up, and I'll beat you to the punch. So I think the general schema for management, and again, there's lots of room for individualization. There's several ways to skin the proverbial cat. I think one of the most driving features is an individual progressing on Revlimid or off Revlimid. Second-line treatment can be a triplet with either bortezomib or lenalidomide or KD, a doublet. Third-line therapy, Pomalidomide, Dex, and usually a third agent, usually cyclophosphamide or KD. Our clinical trials are quite common in this setting. And then more advanced disease, clinical trials become very important. Daratumumab is a single agent, is Health Canada approved. It is not going to be funded and is frustratingly only available through a clinical trial or private insurance. Cyclophosphamide and prednisone can be a very useful holding treatment, even in advanced disease. And we've come to start using cyclophosphamide 50 milligrams, that's 1 pill 1 day, prednisone 50 milligrams, 1 pill the next day. And that can often help energy, symptom, and pain. So again, if we look at breaking this down a little bit more, I think what we'll be seeing is for those patients progressing on lenalidomide, trying to offer Dara-VD, a third line KD or a pomalidomide regimen, and not on lenalidomide, this is where patients will be receiving Dara-RD. So it's just another way of looking at this. Now my summary slides to try to pull this together is there is not one right way to treat myeloma, and I think it's probably important to have access to as many drugs as possible, and one could be a bit cynical and say the order may not matter as long as you have access to these drugs at some point, and that may be the bottom line. It's not only about treating a laboratory value. Sometimes an increase in M protein or free light chains can be simply watched. The field is changing extremely rapidly, and we're going to have these exciting new drugs and antibodies as part of first-line treatment, and we already have better agents on clinical trials for advanced disease. There are many questions. One that we're hearing a lot of is, should lenalidomide be avoided as part of initial therapy so that someone can have DRD as relapse treatment? That's a difficult one because in oncology, we don't like gambling or maybe compromising first-line treatment in the hopes that someone can get a good second-line treatment. The lenalidomide maintenance has dramatically prolonged the benefit of transplant. And again, our real-world data was incredibly encouraging that will be published in the public domain soon. And there's some troubling information that needs to be refined from Europe and Alberta that have indicated that a surprising percent of people don't make it, so to speak, to get that second-line treatment. Is it because they have a heart attack? Is it because they can't get to the center? We don't know, and that is being looked at through the national database. The numbers that are out there in publications are likely way too high. We have the option of adding daratumumab to certain regimens for relapse until June 15th. Should we do that? It might be an important option for patients not eligible for daratumumab later. You need to discuss this with your physician. Anecdotally, we've heard, not surprisingly, that when that happens, you really need to watch the neutrophil counts, because someone's stable on a regimen, you add daratumumab, I think one needs to be prepared to need G-CSF and be vigilant for increased infections. Should we be doing second transplants for relapsed myeloma anymore in this new era? Moving to the bottom part here, we really need to focus on improving the side effect profile and quality of life with these regimens. I think weekly bortezomib has dramatically decreased the neuropathy, pardon me for the typo. Weekly carfilzomib hopefully will be more convenient. We have a trial that has documented that after the first dose, DARA can be given very safely over 90 minutes. And actually at PMH, that's going to be our go-to regimen, which will decrease the amount of time spent with these longer infusions. Dose modification and symptom management is essential to improve tolerance. We can manage diarrhea with Len or Pom. We need to address muscle cramps and use G-CSF. I think many of the questions that I just raised are under review using our national database. So thank you to those of you who have agreed to have your data be included, because we are using this to see how we're doing, looking for opportunities to improve things, define gaps, go to funders. What are our options if our patients aren't eligible for DARA for public funding? Now, some have private insurance, which is just really great, but we are really moving to a two-tiered system. We do have another monoclonal antibody that's on the horizon, another CD38 antibody, and our MCRN trials are committed to bringing immunotherapy to as many myeloma patients as possible in Canada in as many centers as possible. Our MCRN 004 trial that was Michael Sabag was PI has given DARA to 120 Canadians. Our 90-minute infusion is on target for 40 Canadians. That's Julie Stackhughes, the PI. Suzanne Trudell in our center has worked with a very exciting antibody drug conjugate with pomalidomide. The trial's just being enlarged. It'll be well over 50 patients. So as much as we can get these drugs into Canada, there are ESA trials coming up as well. So I think this is my last slide. I think, as you've seen, there are many factors to be considered when selecting treatment for relapse. I think we really are taking into consideration practical factors. The availability of sequential regimens has definitely prolonged disease control and extended survival until we have a cure for this disease. And really, as you'll hear from other speakers, the future is incredibly bright. We are seeing firsthand unprecedented activity with new drugs for relapse disease, the so-called BiTEs, other antibodies, and the CELMoDs are a new class of oral drugs that are in the IMiD lineage that we are seeing some very encouraging response. So I think we thank all our collaborators here. Thank you to Myeloma Canada for bringing us under one roof and allowing us to get together to discuss this progress. Thank you.